I think this becomes a convenience for patients to get that information and also not take up a spot on a schedule if they don't need to be seen face to face to truly operationalize this.
Truly key to doing this and doing it well is just knowing what your process is, because you don't want to put that at risk.
When it comes to cardiovascular care on the organizational level, MedAxiom understands the challenges your program is facing. Welcome to MedAxiom HeartTalk, the podcast where thought leaders come together for one ultimate goal: to continually transform cardiovascular care for all. MedAxiom HeartTalk starts now.
I'm Melanie Lawson, a journalist in Jacksonville, Florida, and host of MedAxiom HeartTalk. We are back, and we are excited to share a new revenue recovery episode today. In this episode, we will discuss how to appropriately capture interprofessional consultation services. And as always, we have added a cheat sheet to the episode notes, hoping to make your lives just a little bit easier when accessing this information. So I am excited once again to introduce today's guest. Both are familiar voices for our Heart Talk listeners. First up, we have Nicole Knight, Executive Vice President of Revenue Cycle Solutions and Care Transformation here at MedAxiom. And Linda Gates-Striby, MedAxiom Consultant, Revenue Cycle Solutions. Welcome back to the podcast. You guys like it here, don't you?
It's great to be here, Melanie.
Yeah, it's good to be back. Thank you.
We always have such good conversations too, so I'm glad you're back with me today. We do have a quick reminder though, as a refresher, you can find the first 5 episodes of this series in your podcast app under the Revenue Recovery title, and we always have links in the episode notes as well. All right, so Linda, set the stage for us. What exactly are interprofessional consultation services, and what CPT code are we talking about?
It has a long description. It's 99451, interprofessional telephone, internet, or electronic health record assessment and management service provided by a consultative physician, including a written report. Verbal report is not required, and it's going back to the patient's treating or requesting physician or other qualified healthcare professional. It does have a time requirement, 5 minutes or more of medical consultative time. So I do want to point out that in the event this service does also involve a verbal discussion, there are codes that are time-based that represent that verbal discussion plus the written report. And those are ones that we're not going to focus on today, but if you want to make a note, it's 99446 through 99449. So this session, we're focusing on the 99451, which can be nothing more than that electronic medical health record review and then a response back.
Sounds like we have a topic for a future episode with the other codes that you listed, but we will stick with this 99451. So Nicole, what is the average work, RVU, and CMS reimbursement payment for this code?
Yes. So for our Medicare physician fee schedule, our national reimbursement is about $35, may vary with your local carriers. And the work RVU is 0.70. So this is for our physician services that are provided, and that's in the office setting in reference to this. There's also some co-insurance that may apply because, again, this is a billable service that's reimbursed both by Medicare and many of your commercial payers.
And Linda, what are the requirements for capturing this code?
Well, as we mentioned, it is time-based. So if it does not take the minimum requirement of 5 minutes, it wouldn't be eligible. And any time you have a time-based code, you must document that actual time. And for this particular code, it doesn't matter if the patient is a new patient or an established patient, but it does have a couple caveats here. One, that the consultant should not have seen them face-to-face in the previous 14 days. And if this consultation leads to ultimately a transfer of care or another face-to-face service, in the hospital or surgery or a hospital visit within the next 14 days or the next available appointment, then you cannot report the code. So I know in our practice, we have an edit built that when the clinician drops the code, it looks back 14 days, then it holds it for 14 days, then it releases the code. So that what we want the clinicians to do is just render the service, render the code, and we'll let the system do that extra work for us.
Linda, that's great. I mean, that's definitely taken out a middleman and extra eyes to have to look at that and monitor it before and after it's rendered. Nicole, what should listeners know about coverage eligibility for this service?
Well, for this particular service, it does require patient consent. And that always, Linda and I, when we've talked about this in various conferences and in talking with physicians, it becomes, it's not informed consent by a physician. It may be covered by your general consent policy, and you may have verbiage in there that covers those non-face-to-face services. But it's important to note this is not an formal written consent by a physician. This is truly verbal, or it could be written consent that's represented in your general consent forms around non-face-to-face services. So don't get hung up on that consent process, because they have changed this to be a verbal consent that's documented, or it can be part of your general consent and not that formal consent from a provider.
That's important to understand. Thank you. Great information and a great place to pause for a quick message for our Heart Talk listeners. You hear the term care transformation a lot, but what does it mean exactly? Care transformation is redefining the way consumers buy and use healthcare by developing new products, treatments, and business models that integrate separate healthcare organizations or activities. MedAxiom understands that moving the needle in CV care is not simple. It takes vision and leadership, and it requires bridging technology, innovation, and care delivery. MedAxiom experts are helping programs across the country shape the future of cardiovascular care delivery. Through education, organizational performance solutions, and advocacy, we are evolving disease management, innovating virtual care, driving the data revolution, and redefining access and team-based care. Let's transform cardiovascular care together. Get started at medaxiom.com/care transformation. Welcome back. We have been discussing revenue recovery with industry experts Nicole Knight and Linda Gates-Striby, specifically capturing interprofessional consultation services. Let's dive a little bit deeper, as hope you were listening as we really kind of talked about what it is and how we can utilize it. So Nicole, what is a potential use case for interprofessional consultation services, and can this sometimes be challenging to capture?
It can sometimes be challenging to capture, as Linda talked about the great things that they've set up in their systems, and I would say that's essential. But where we see the best use case for this is around our pre-op services. So if a patient needs a risk assessment, or what we call clearance, for a procedure, they often send in numerous amounts of paperwork requested by their consulting physician that's doing the procedure. They need those forms filled out in order for them to move forward with their procedures, such as cataracts, such as a colonoscopy, or any of those procedures. And they may have just been seen by the physician. They meet that 14-day criteria, and they don't need to come back into the office. So the physician or an advanced practitioner takes that time, they review the history of that chart, they complete those forms, and they provide that correspondence back to the physician requesting that information, and the patient doesn't have to come into the clinic. So they've gotten their pre-op evaluation through that written context. They've gotten the expertise of their cardiologist to weigh in on their care and management. And this just provides a way for them to do that through that written time-based activity by their provider.
Mm-hmm. And Linda, we always kind of talk about this because we know our listeners may or may not be the people literally coding the services, but they are responsible a lot of times for the program's overall success with revenue recovery. So we ask you, what are those top implementation tips for capturing this service to really put this into action?
Well, I tell you, one of the most challenging is just capturing the flow of these requests through your office. Are they coming in via fax? Are they being scanned in? Are they phone calls? So knowing that flow, are they electronic, faxed, paper? What are we doing there? And you could consider identifying those top physicians requesting that clearance.
Mm,
Could their request include a statement that, that they've made the patient aware of the potential need to be seen and or that medical record review that kind of speaks to that consent piece. But just knowing how your system deals with a charge that does not also have a scheduled appointment, that's the big one. Because since these patients, we if we need to see them clinically, this isn't going to change our clinical criteria. We'll still see them. They're not a candidate for this. But
mm,
those patients who are perfectly stable, you saw them a month or so ago, you have no concerns whatsoever about them undergoing that EGD. You're just going through this process. How do you capture the charge? Because it doesn't have an appointment to link it to.
mm,
So what we've decided to do and what works really well is we created a shared file so that the nurses who are involved in that process, so that they start the information with the patient's name and date of service, and they route it to the clinician just like they normally would. A lot of our electronic record systems use routing to send a message from the doctor to the nurse or the nurse to the scheduler or whatever. As they route it, they start the entry. So the clinician responds as they always have, including the time, routes it back to the nurse. The nurse then puts the time on that log, and the
mm.
biller can go in and then drop the charge. And then when we have them highlight off of that log as they do it. So, truly key to doing this and doing it well is just knowing what your process is, because you don't want to put that at risk for that requesting physician not getting what they need. But how do you jump in the spot to capture the charge? That is one of the bigger challenges.
Mm, mhm. Nicole, circling back as we always do here at MedAxiom, is that we want to keep the focus on the patient. How does this benefit the patient by capturing this service?
Yeah, so patients often have scheduled these procedures. They've had to make transportation arrangements. They have a date and they need their specialist to provide this information. We all know it's not easy to get in a short time frame to
Mhm,
have that face-to-face visit. So if you qualify for this type of written and electronic review and you're able to get your clinician's input on your procedure and move forward timely, I think this becomes a convenience for patients to get that information, particularly around the cumbersome forms that need to be completed. And it gives our practices a way that their advanced practitioners can also help provide this service to our patients, have that time frame to turn it around quickly, and also not take up a spot on a schedule if they don't need to be seen face to face, to truly operationalize this and move that patient through the process to get their procedure timely.
yeah, I love that. I mean, I think no, like we were saying earlier in the conversation, off the mic, that we would rather do things at home, more efficiently and not have to get to the doctor's office. So it does truly benefit the patient in that way. Linda, Nicole, anything else that you all would like to add to our conversation today?
I just add from the financial perspective as well, you know, different insurance coverages. I mean, it's very typical that the insurance coverage will allow a certain percent, pay 80% of that, and then the remaining goes to the patient's secondary insurance, in
Mm,
which the patient has no out of pocket, or it goes to the patient. And when there is that copay that goes to the patient, it's often less than an office visit. So another thing that this provides to our patients is they don't have to go through the transportation to and from. I mean, a lot of folks don't like fighting that traffic. I'm one of them. And waiting in the waiting room, they can just be at home, get the information they need, And a lot of times the only feedback we get from the patients is thank you.
Mm.
Thank you for saving me that.
Yeah, I think it's important the provider think of it that way. It does make it much easier to capture this. Nicole, Linda, thank you so much for sharing your time and, of course, your expertise today on MedAxiom Heart Talk. Always love talking with you.
Thank you, Melanie.
Thanks, everyone.
And that is it for this episode. If you liked it, please tell your colleagues and let them know. They can always subscribe to MedAxiom Heart Talk on Apple, Google, or wherever they get their podcast. Also, if you'd like to send us a note or suggest a topic, email us at hearttalk@medaxiom.com. Appreciate you listening.